RBS was 170 milligram per deciliter. Her GC score was there was eye opening, 4 full eye opening. There was full verbal response, and her motor movements were all good. It was 6 E4 V5 M6. Her GCS was full. Her pupils were bilaterally equal and reacting to light equally. On arrival, her temperature was 101 degree. She had fever. And in our secondary survey, when we assessed the history, there was her symptoms was there was dyspnea on exertion for the past 2 weeks and fever and cough for the past 1 week. No history of any non-allergies. She had a regular menstrual cycle with menstrual history, regular cycles with 30-day cycles, but there is no significant past history, no significant no comorbidities, that is no non-comorbidities or any other significant history in her past. And she came around 12 p.m., that is 12 afternoon, and her last oral intake was in the morning. And the events was like she had complaints of dyspnea on exertion for the past 2 weeks, and that worsened to dyspnea at rest over the past 2 days, and there was no chest pain. She had fever for the past 1 week, and it was intermittent low-grade fever with approximately 2 episodes per day. There was no chills or rigor, no evening rise of temperature. She does not complain of any headache, no vomiting, seizures, or altered sensorium. There was no upper respiratory symptoms, sore throat, no abdominal pain, loose stools, no skin rashes, arthralgia, myalgia, oral ulcers, or any photosensitivity reaction. She had cough. It was productive with mucoid sputum since the past 1 week. There was no pleuritic chest pain associated or no hemoptysis. She does not complain of any hemoptysis. Next, we'll move on to the head-to-foot examination. There was no alopecia. She had significant pallor. There was no neck vein distension. She had bilateral pedal edema, pitting pedal edema. There was no icterus, no cyanosis, no clubbing, and no lymph adenopathy. Then we move on to the systemic examination. The respiratory system, there was bilateral crepitation present. Air entry is bilaterally equal. Then on checking the cardiac system, there were muffled heart sounds, but the S1, S2 sounds were heard, but that was muffled heart sounds. Per abdomen examination, it was soft, non-tender, normal bowel sounds plus no visible dilated veins over the abdomen. Then on over to the CNS examination, there was no focal neurological deficits. She had her pupil reacting bilaterally and equally to the light. Then we reached our working diagnosis in our ER with her presentation and with our assessment with the initial primary survey, then the secondary survey, then the head-to-foot examination, and from the system examination, we came to a conclusion that we came to a working diagnosis that she had a community acquired pneumonia, or it could be an atypical pneumonia, or it can be a SARS-CoV pneumonia or a viral infection with a pericardial effusion we suspected because of the muffled heart sounds. Then we moved on to the investigations. We advised chest x-ray, and then the chest x-ray showed, this is the chest x-ray of the patient. She is the 30-year-old lady. Her chest x-ray is shown here, and it showed the cardiothoracic ratios increase. There is an enlarged cardiac pillow, and it suggests it is a suggestive of the cardiomegaly, and also there is a possibility of pericardial effusion. So we suspected that. Then from the ECG finding, we got a sinus tachycardia with some low voltage complexes. Then we had the ABG report. The ABG report shows the pH is 7.43 with a PO2 of 80. Then carbon dioxide is 18, the bicarb is 13, the electrolytes is like sodium is 130, potassium is 3.4, a chloride of 115, and an anion gap of 12, and her lactate was 1.2. And this was taken when the patient was on NIV with a 14-6 setting with 5 liters of O2, oxygen. And this ABG showed, from this, we came to the conclusion of a primary respiratory alkalosis with the type 1 respiratory failure, with a metabolic acid, with a compensated metabolic acidosis with the normal anion gap. Then we did an echo. Actually, we did a bedside echo in the emergency department itself, and there was a moderate pericardial effusion in that bedside echo. And this report is the one which we consulted the cardiologist, and it was done by our cardiologist, Dr. Santosh, and we got the echo report as there was a moderate pericardial effusion, 2.7 centimeter over the lateral LV wall with a 2 mm over the apex, 1.6 centimeter posterior and 1.6 centimeter over the right ventricle, with no evidence of any cardiac tamponade. With these investigations, and we took the CT chest, and in that CT thorax, we got this is the video showing the film of the CT thorax, and in this we can see the pericardial effusion clearly. Here comes the that is the rim of the pericardial effusion is shown in this can be viewed in this CT film of CT thorax. Then with this, we reached a provisional diagnosis. We reached a provisional diagnosis that we came to a diagnosis of a lower respiratory tract infection with a patient presenting with a pallor and also a pericardial effusion. So we not concluded. So we reached another diagnosis. It could be a viral pneumonia with a pericardial effusion. Once we got a provisional diagnosis from the emergency department, we consulted our physician, Dr. Suraj. He is a senior physician, and also we consulted Dr. Janak. He is our clinical nephrologist, and also we consulted Dr. Santosh, our cardiologist. Then the patient was further evaluated for the remaining blood tests. Everything was routinely checked up, that we'll discuss in the coming slides. Here I'll discuss about some causes of the pericardial effusion. Some of the causes of the pericardial effusion, it can be common causes, it can be idiopathic, like it can be due to viral, post-viral or immune-related infection, or other infections like bacterial infections. It can be mycobacterium tuberculosis. Fungal infections can include histoplasma, aspergillus. Other parasitic infections can also result in pericarditis, pericardial effusion. Then the non-infectious causes include some autoimmune disorders or autoinflammatory disorders. It can be rheumatoid arthritis, SLE. This table shows all. This table gives an idea of the autoimmune as well as autoinflammatory diseases. There are many diseases. It can be systemic inflammatory diseases. It can be autoinflammatory diseases. Can be due to post-cardiac injury syndromes or other vasculitis or venous granulomatosis, polyarthritis nodosa, etc. Then it can be due to malignancy. It can be due to metastatic or lung fibrosis, lung or breast cancers. Then it can be due to teratoma, fibroma, lipoma, or it can be paraneoplastic. This effusion can also be due to the cardiac causes. It can be due to early infarction pericarditis or any myocarditis or late post-cardiac injury syndromes. Also, it can be due to trauma, which can be a blunt trauma or a penetrating trauma. It could be due to metabolic causes like hypothyroidism, uremia, ovarian hyperstimulation syndrome. It can be due to radiation, and rarely it can be due to some drugs. Then in this particular case, this lady is a 30-year-old female. So the common causes of the pericardial effusion in a young female, with no non-comorbidities or no non-comorbidities, as well as no significant history of anything or any significant family history. So we need to suspect some common things, that it can be mainly due to infections. It can be due to some autoimmune pathologies. It can be due to malignancy, or it can be due to a primary cardiac pathology which was undiagnosed. So this viral pneumonia with pericardial effusion, this infection, it can be tuberculosis, atypical infections, or viral infections. In case of a primary cardiac pathology, it can be due to myocarditis or any infective pericarditis. In autoimmune disorders, it can be due to SLE, that is systemic lupus erythematosus, or vasculitis, or any other systemic disorders. In case of malignancy, we can suspect fibroma, lipoma, or any other metastatic carcinoma. So moving on to the blood investigation reports. This lady was admitted in our hospital this lady came to our hospital on April 19th, that is 19/4/2022. Around afternoon, she came to our hospital. So we did the routine blood investigations in our emergency department, and the blood reports showed the total counts were 4,800. There was a significant HB drop that was 8.5 with a CRB of 59. She had a creatinine of 1.32. Her sodium, the electrolyte, that is, there was hyponatremia. Her sodium was 125 with a potassium of 5.5. And she had very high BNP levels as well as D-dimer levels. It was around 10.12 D-dimer and a BNP of 2,480. Her LDH was highly elevated with 377. Then on checking the liver function test, her bilirubin was normal. It was 0.5. Her SGOT and SGPT was normal. Her serum albumin was 2.9. And the urine routine examination showed an albumin of 4 plus with 10 to 12 RBCs and some granular CAS present. Troponin I was done, which was 128. Uric acid was done, it was 7.7. And the hormonal assay showed a ferritin of 228. The free T4 is 1.76 and a TSH of 3.69. Her INR was around 1.7. And we also checked the anemia profile to look for any other iron deficiency anemia. The iron was 11. Her total iron binding capacity was 209. Transferrin saturation showed 5 and with a reticulocyte count of 2.9. Her viral markers were negative. Then her peripheral smear was sent. We did a urine protein, 24-hour urine protein. The next day it came, and the next day we got the report as 1,350 milligram per 24 hours was the urine protein 24-hour report. And the peripheral smear also, after the next day, the peripheral smear, once she was admitted, the peripheral smear was sent, and we got the report the next day, and it showed mild hypochromia, mild leukopenia, and neutrophilia. Then we did further investigations. As we there was anemia, marked leukopenia. We show this report showed marked albumin in the urine, that is albumin 4 plus, that is proteinuria, and we saw that there was serum albumin was 2.9. So we did some other extra investigations to rule out things correctly. So we did a DCT. There was a direct Coombs test done, which showed positive report with a 3 plus. Then the LDH was 377 and the retic count showed 2.9. So we suspected another thing, that is autoimmune hemolytic anemia, because we showed there was a Coombs test showing 3 plus positivity with an LDH of 377 and a retic count of 2.9. And again, we can suspect this underlying iron deficiency anemia because there is a transferrin saturation of markedly lower, that is about 5% with the peripheral smear showing this mild hypochromia. So again, we suspect autoimmune hemolytic anemia with underlying iron deficiency anemia. So we reached the we got some more diagnosis, that is we reached some more we got some more disorders in this lady, that is this from the blood investigations. This blood investigation showed, and from the blood investigations we got we reached these much conclusions too. So she had anemia, she had severe leukopenia, and she had subnephrotic range proteinuria, and she had pericardial effusion. Along with that, she had a constitutional symptom of fever with a 101 degrees Celsius. Then we did the further blood tests, blood examinations, and in that the urine PC ratio was 2.8. The complement C3 level showed 0.42, which is too low. The complement C4 also showed less than 0.02, which is also very low. So the C3, C4 levels were very low. She had a urine protein creatinine ratio of 2.8. She had fever with anemia, leukopenia, a subnephrotic range proteinuria, and the pericardial effusion. So according to the ACR-ULR criteria, that is the European Alliance of Associations of Rheumatology and American College of Rheumatology classification criteria for the systemic lupus erythematosus. This is the for the criteria for deciding the systemic lupus erythematosus, that is SLE, ACR-ULR criteria. So the entry criterion is ANA at a titer of more than 1:8 on Hep2 cells or an equivalent positive test ever, and at least one clinical criterion required to classify SLE, and additional additive, that is clinical or immunology criteria, are counted toward the total score. And we have clinical domains as well as immunological domains in this ACR-ULR criteria. And first we'll check on the clinical domains, and the clinical domains include the constitutional things, hematology, neuropsychiatric, mucocutaneous, and the serocell, musculoskeletal, and the renal system. And this marked things with yellow is those symptoms our patient had. So she had fever. That is the constitutional side. She had fever, so it gives 2 points. She in the hematologic domain, she had leukopenia and also autoimmune hemolysis. It gives 4 points. Again, our patient had pleural or pericardial effusion, and our patient had pericardial effusion, and it gives 5 points. And in the renal system, she had a proteinuria of more than 0.5 gram per 24 hours. That gives 4 points. And again, in the immunology domain, it gives extra add up, that is there was low C3 and low C4. It gives 4 points, and this gives a total of 19 points fitting onto this ACR-ULR criteria for SLE. So a total score of more than 10 and more than or equal to 1 clinical criteria is required to classify the patient as SLE. In our case, this patient is having in this ACR-ULR criteria, she is fitting into this criteria, and her symptoms give a total of 19 points, with the our clinical features itself is giving 15 points, and from the other immunology we are getting 4 points. So actually a total score of 10 and 1 clinical criterion are required, and it is including more than 4 clinical criterion. So we came to the diagnosis of SLE because according to this criteria, this patient is satisfying more than 10 points, and it is suggestive of systemic lupus erythematosus. Along with that, other blood, as we suspected this one, so parallelly we did many other blood investigation. We did the ANA immunofluorescence, which was positive 3+. It was 3+ positive with nuclear speckle. Then dsDNA was positive, and the APLA was done, which was negative. So in this, we came to the diagnosis of systemic lupus erythematosus. As we discussed above, there are many other diagnoses, that is many other differential diagnoses for a case of viral pneumonitis with pericardial effusion. So we need to rule out the other causes too. So TB is one of the most common infection in which there can be in which the patient can present with viral infection with a pericardial effusion. So we ruled out the tuberculosis by doing the sputum culture, sputum gram stain, sputum AFP smear, sputum AFP culture, and also sputum gene expert, which all showed negative report, and a quantiferon TB gold was done, which was also negative. So thus we ruled out TB, which is one of the common thing. Then after 2 days, we did a renal biopsy. This patient came on 19th of April, and this was done on the 21st. She was admitted, she was evaluated, her treatment was started, and the renal biopsy was done once her dyspnea and once she was clinically stable. That is why we waited for 2 days, one for her dyspnea and her clinical condition to settle. So we did the renal biopsy. It was done, and it showed the clinical impression of a suspected case of SLE with a lupus nephritis of class 4 or 5. This was the clinical impression from renal biopsy. In the renal biopsy, the light microscopy gives us some changes. We can see in this image, this is the image of the renal biopsy. This is the renal biopsy report of the patient, and it shows some light microscopic changes, and that is the glomeruli reveal diffuse moderate mesangial hypercellularity. then hyaline thrombi, segmental karyoresis, and then fibrinoid necrosis. Tubules reveal epithelial vacuolation. This light microscopy reveal many positive findings, and from the diagnosis, we'll get an activity index of 9/24 and a chronicity index that is 0/12, which is not significant, but the activity index is 9/24. So we came to a final diagnosis, that is SLE flare. Why did we say that it is SLE flare? Because the patient had clinically, she came with complaints of fever, she had pneumonia, she had nephritis. Serologically, while looking at the blood test, she had very low C3, C4 levels, as well as increased dsDNA, that is positive dsDNA. Then she had elevated ESR levels, and also she showed serositis. So it is SLE flare that we can classify. We can say it as SLE flare, that is a systemic lupus erythematosus flare changes. So we came to the final diagnosis with the initial our investigations. First we had a working diagnosis, then we came to a provisional diagnosis. Then following that, we did many investigations like X-ray, ECG, echo, ABG. Then we did the blood examinations. From that also we came to we got some more diagnosis. Then again, to confirm that and to rule out many other things, we did furthermore evaluation of the patient, and we came to a final conclusion, that is the patient's final diagnosis, that is serositis with a massive pericardial effusion, but with bilateral minimal pleural effusion, ascites, then lupus nephritis with class 4, that is biopsy proven, and an activity index of 9/24, pneumonitis, then DCT positive autoimmune hemolytic anemia, then underlying iron deficiency anemia, and a leukopenia. Then to the management, she was managed initially with IV steroids. Then we had IV steroids, which was initially started at high dose, then it was tapered to the lower doses. So first we started on IV steroid pulse therapy with IV methylprednisolone with 2 mg/kg for the first 2 days. Then it was tapered to 1 mg/kg for the next 3 days. Then she was started on oral steroids. That was tapered to oral steroids with 1 mg/kg. It was tapered and then continued. Then we started on then TAB HCQs. It was started with 200 mg BD and it was continued. Then in case of when we suspect the patient with SLE, we start on cytotoxic drugs also. So when to start the cytotoxic medications? If there is any evidence of life-threatening or any organ-threatening damage, there is a need to start cytotoxic medications. This can be myocarditis, cerebritis, GI vasculitis, lupus nephritis, diffuse alveolar hemorrhage. These are the common things that I mentioned. That is the evidence of life-threatening or organ-threatening damage. We have to start on cytotoxic medications. In view of the above mentioned conditions, we came to another conclusion of lupus nephritis, and the patient was started on mycophenolate mofetil, MMF. Why we start? We can use cytotoxic medications like MMF. We can use cyclophosphamide, etc. But in this patient, we use mycophenolate mofetil. Why the patient was started on mycophenolate mofetil? What was the advantage of MMF over cyclophosphamide? In the Asian population and the young female of reproductive age group, we started on MMF because cyclophosphamide is not preferred because it can result in fertility issues. Some studies showed it can result in fertility issues. So we started the patient on mycophenolate mofetil with 1 gram twice a day. Then further, this MMF started regimen. We start as we have an induction phase and a continuation phase for starting mycophenolate mofetil. The induction phase is for the first 6 months. For the first 6 months, we'll start with 2 to 3 grams per day, and in the continuation phase, it is over the next 2 to 3 years. Then we'll continue with 1 to 2 grams per day. The induction phase is the first 6 months. In that, we'll go with 2 to 3 grams per day. And next is the continuation phase for the next 2 to 3 years, that is 1 to 2 grams per day. So we started on the patient initially with 1 gram BD. That is initially we started with MMF 1 gram. Then further management, again we evaluated the patient. The patient was initially the steroids. It was started with, as IV steroids. It was then tapered to oral steroids, and still the patient is continuing on oral steroids. Also, the TAP HCQ initially it was started with 200 milligram, then it was tapered to 100 milligram, and still the patient is continuing for the past 7 months. And the cytotoxic medication, again initially the MMF was started. And again, it is also tapered and the patient is continuing, and the patient is currently on Dr. Janak's follow-up. This is the follow-up one, and this is just a comparison just to know how the patient improved clinically, as well as how the patient improved clinically. Just some of the reports for a comparison. At presenting on April, she had a very high elevated ESR of 70. And later in November, when we did the blood examination, she had an ESR of 4. Then anti-dsDNA was 232. Then later in November, when we repeated, it was 86. We routinely repeated most of the blood tests, and this is just a comparison for over 6 months. Comparison for over 6 months. That is from April to November. I'm just giving some of the reports for a comparison only. She was on regular follow-up under in our nephrology department. Then again, complement C3, it was initially less than 40. And then in November, it was 83. Again, urine albumin initially was significantly, she had 4+ albumin, and in November it was negative. Then the current treatment is she's on oral steroids with 7.5 gram and 7.5 milligram and 5 milligram alternatively. Then MMF 1 gram twice a day, and HCQ as 100 milligram twice a day. These are some of the studies, study reports, some presentations and some study reports of this pericardial effusions with SLE for an SLE patients, that is large pericardial effusion due to SLE. Again, another massive pericardial effusion, some uncommon presentations of SLE. That is what is shown here. Thank you so much.
Thank you, Dr. Amitha, for that excellent presentation, and the slides also were very good. Well, we expect you back with more cases in our clinical club in future. Okay, Dr. Prinish, please comment on this topic. Dr. Prinish Mohanan.
Hello. Good evening, sir. Can you hear me?
Yeah. Go ahead.
Okay. So initially, patient presented here. I and Abhiraj there. So initially, we received the patient with the complaints of only breathing difficulty and fever for the past 1 week, and along with the breathing difficulty. So we initially evaluated as same of that of the routine LRT.
Prinish, you're having a lot of echo. Do you have a second device on in your room?
Hello?
Please go ahead.
Hello? Hello? Hello?
Yeah, nice, better.
Is it okay now, sir?
Yeah, better.
Okay, sir. So initially, the patient presented with only the complaints of fever, shortness of breath, and cough. So initially, we received the patient as a normal respiratory case. So after evaluation, the further evaluation, so we routinely do echo for all the patient with sick patient with a respiratory complaint or decreased saturation to rule out any cardiac causes also. So we did a screening bedside echo. So at that time, we found that there is some significant pericardial effusion is there. So after that, we found that pericardial effusion. We discussed it with Dr. Santosh, cardiologist, and along with the Dr. Suraj and Dr. Janak. So Dr. Janak and Dr. Suraj say the patients at the ER itself also. Then they said that we have to evaluate further for a young lady who present with a fever along with the pericardial effusion. We have to rule out any other causes. There are a lot of causes are there. So we did all the initial investigation. From there also he had significant changes in the blood report. Not only regarding the LRTI picture, is something else is present. So we transfer the patient to Dr. Suraj side. Dr. Suraj and Dr. Janak evaluate further. So after 2 days, they come to the diagnosis that it is a possibility of SLE is there. So that's a special case for this. We initially, if we miss out the pericardial effusion or we miss out the case, we simply treated this as a LRT picture. So from the initial point of time, we can pick up the findings and we can consult the corresponding department for the further evaluation. So we are happy with this case. So that is why when we have an opportunity to present the case, so we selected this as a case. So Dr.Amitha presented nicely, and for this also Dr. Janak helps a lot for preparing for the presentation because he and Dr. Suraj routinely updated the finding because we always ask the follow up of the patient. So that's it. So for further clarification, Dr. Janak can help more.
Thank you, Dr. Prinish Mohanan.
Thank you, sir.
That explained. You've tried to explain more. And Dr. Janak also is in the team. Dr. Janak, please.
Am I audible, sir?
Yeah.
Good evening, everyone. First of all, I would also like to thank the IMA Association, Pradeep sir, and PRS Hospital for giving us this opportunity to present this very interesting case. So, as Dr. Prinish already told, I think Prinish and Dr. Amitha have already told everything about this case actually. So, first day itself, actually, I wasn't able to see this patient on the first day. I saw the patient on the second day. First day itself, I think the majority of the credit goes to Dr. Suraj itself. He was the physician in charge, and he is the one who correctly pointed towards the diagnosis of SLE on the first day itself. So I think what are the main points over here? Like the learning points that we can take away from this particular case is such an uncommon presentation, probably not the rarest presentation of SLE, but it's not a very common presentation of SLE. Usually you see SLE patients presenting with typical joint pain, skin rashes, oral ulcers, photosensitivity. She did not have any such significant symptoms over the past few months. She presented with an acute presentation of a lower respiratory tract infection sort of a symptom with a massive pericardial effusion. So obviously the first TDs that we think in such a patient will be obviously some sort of a viral pneumonia or TB, so and so. So I think what were the highlight points or the catch points in this particular patient was the presence of the significant proteinuria actually. Significant proteinuria with active urinary sediments. So she had 4+ albuminuria with RBCs also. So that is what pointed towards the suspicion of a possible secondary glomerular etiology. That is a systemic disease causing a secondary glomerular disease. That is what we led to us to suspect the possibility of SLE. And obviously there were other features also like a DCT positive hemolytic anemia actually. So all these things were favoring more likely SLE. Obviously, hemolytic anemia, pericardial effusion, fever, constitutional symptoms all can happen with lymphomas also. So I think proteinuria once again goes more in favor of SLE, and by that time the immunological profile also came, all of which were fitting into SLE. So what is important is obviously making a suspicion of SLE in any such patient, because when she came actually she was markedly sick actually. She was in severe respiratory distress, was on NIV actually. And a very simple thing like just a good dose of steroids actually led to a significant improvement in her clinical status over just one day. I saw the next day actually. By the time I saw the next day itself, she was off NIV support on minimal oxygen, so she was maintaining saturation on. That is the magic of steroids in a case like SLE. So when to give steroids, when to suspect SLE, I think is very important, and we need to make a rapid clinical diagnosis because all of us know that SLE is a life-threatening disease. especially a patient coming with SLE flare, patient can immediately, very fast succumb actually. Within a period of 24 to 48 hours, the patient can succumb if we do not diagnose the disease fast and start the treatment. Treatment is also quite simple in the initial phase. So that is probably the most important learning point that we can get over here. And all hats off to the Department of Emergency Medicine and Internal Medicine, Cardiology, everything for coming up with this diagnosis. As I said, my role was probably 1 or 2 days later. Once the patient stabilized, I went ahead with the renal biopsy, and also we found that she had a class 4 lupus nephritis, which is probably the most severe form of lupus nephritis, which warranted further cytotoxic agents in her. And we started mycophenolate mofetil, and with which she's right now better. But obviously, we know SLE is a very tricky disease. We have to balance both immunosuppression, against the chance of opportunistic infections also. So balancing both is extremely important. SLE can just come to us in a moment's notice, and like the patient can go within a blink of an eye actually. And opportunistic infections also are very, very common in these patients. So we have to be on the lookout at every moment for opportunistic infections also, and also have to give prophylaxis also. That is also equally important. This patient was also put on PCP prophylaxis for the first 2 to 3 months because she was on high dose steroids and high dose immunosuppression, after which we could stop it. So all these things I believe are the learning points, and we should always be on the lookout. That's what for these kind of typical features actually, proteinuria, all these things we should be on the lookout in such clinical presentations. Thank you.
Thank you, Dr. Janak, for that very good explanation and giving that take-home message. Good. Now the case is open for discussion. Anybody want to add anything more?
Dr. Sangeeta, are you there? I see Dr. Sangeeta, who I think is a nephrologist from Anantapuri Hospital. Any other nephrologist who has joined us? If you have any comments or questions. I have a question to Dr. Janak. First of all, I want to congratulate Dr. Amitha for this excellent case. In fact, Amitha should move from emergency medicine to general medicine, I think, because she has worked up this case beyond her specialty and gone into the nitty-gritties of the depth of the case, which honestly, not something all the emergency medicine PGs show the passion to go and follow up their case and go into the detailed diagnosis and workup, and it always helps them to get a broader perspective of these cases. And when these cases come for relapses and other emergencies in the ER, they can get a better sense of the case. So special congratulations to Dr. Amitha and the PRS team as a whole. So Dr. Janak, you guys have gone all the way to getting a renal biopsy, which helped you kind of solidify the diagnosis, I believe. Could you, without the biopsy, could you have clinically diagnosed lupus nephritis and treated?
Actually, this patient actually fulfills the biopsy requirement in such a patient actually. Only if there is some very strong contraindication to biopsy in such a patient, like presence of significant thrombocytopenia, bleeding diathesis, or if the patient is significant hemodynamic instability or something, only will we not go ahead with the biopsy. In any SLE patient, basically the criteria is persistent proteinuria more than 500 milligrams, which is further estimated with 24-hour urine protein, which is also more than 500 milligrams. We go ahead with the renal biopsy, or presence of active urinary sediments with proteinuria. Definitely the next go ahead step is renal biopsy. Or if the patient has renal failure, which does not have any other alternate explanation other than lupus nephritis, we definitely have to go ahead with a renal biopsy. Now, this patient, clinically itself, we suspected the possibility of a class 4 or a class 5 lupus nephritis on the basis of significant proteinuria with this active urinary sediments, that is 10 to 12 RBCs were present. And based on a serological picture, she had a significant flare actually. C3, C4 was low, dsDNA was high, and she had marked extrarenal manifestations also. So all these things are pointing towards SLE flare, and most likely there is a renal involvement. Now, it is extremely important that we do a renal biopsy in such a patient for multiple reasons. So first is like to characterize what type of a lesion we are dealing with, whether it is just a class 3 or a class 4 lesion, which is a most severe form of SLE lupus nephritis, which warrants very strong immunosuppression with cytotoxic agents, or whether we are dealing with a slightly more benign, not the most benign, but slightly more benign lesion like class 5, which is the membranous nephropathy with nephrotic syndrome usually. So this patient had marked proteinuria, few RBCs, no significant renal failure. So class 5 was also in the picture. So class 5 doesn't require such aggressive immunosuppression like class 3 or class 4. So that is the rationale for doing a renal biopsy in this patient. Definitely, from whatever I said, like from the urine picture, from her serological picture, definitely lupus nephritis was our clinical impression actually. But this is the rationale for doing a renal biopsy, because we need to prognosticate the patient and we need to check for how long we have to give immunosuppression. So in class 3, class 4 lupus nephritis, we have to give immunosuppression for a period of minimum 3 to 4 years. That is what Dr. Amitha also pointed out, 6 months of induction regimen with at least 3 to 4 years of maintenance. And ideally what they say is we have to do a repeat biopsy at the end of maintenance phase to confirm that there is no histological activity in the kidney. What I'm saying is, like, even though the patient has no other clinical evidence of SLE flare, if the C3 is normal, C4 is normal, there's absolutely no urine proteinuria, anything is there also, patient can still have histological evidence in the biopsy of active disease actually. In such patients, we have to actually indefinitely continue maintenance regimen. So that is the rationale of doing renal biopsy in each and every patient who warrants a renal biopsy in SLE, if you are clinically suspecting a lupus nephritis.
Thank you for that detailed answer. Anybody else from the audience have any questions related to the case?
Anand?
Yeah, Dr. Shiju, please go ahead. Dr. Shiju is an emergency medicine HOD from Anantapuri Hospital. Please go ahead, Dr. Shiju.
Nothing much to say. It's actually to appreciate the PRS emergency team and other supporting department, medicine and nephro. Nothing much to add. Just want to add, as PGs are here, not only the PGs, even other departments, any case comes to the emergency with the dyspnea. So right now, they have pointed out the symptoms initially with the exertion dyspnea, followed by acute dyspnea. They have found out acute dyspnea causes the symptoms correlating the infection, so respiratory or cardiac. So this is a way the most of the time we will get most of the cases, especially in tertiary case centers. So whenever a patient comes to emergency with the dyspnea, making a habit, the primary cause followed by rule out other causes also. Not only for dyspnea, I'm telling you, even chest pain also. All killer chest pains you are ruled out. Similarly, dyspnea comes, the system most commonly involved is respiratory, cardiac, renal system, or metabolic. So this is the way you have to go through. So even the symptom is purely respiratory cough, dyspnea in that way, go for excluding other causes also, cardiac cause, renal cause, metabolic cause, even underlying any other substance. So easily you can come to the diagnosis. So what are the points to be ruled out? This is the way they have gone through. So initially respiratory, then to cardiac, then the renal system, because based on other investigation, we have come across to the final diagnosis as SLE. So whenever it comes to patients comes stabilization, followed by ruling out the differential diagnosis, then easily you can make it up. So this is what I have to add it on. And one more thing, in the presentation, she has done very well presentation. One thing I have to add is, after primary survey, better to make a habit of going for adjunct to primary survey. Just for the presentation purpose, I'm telling as an academic point. So adjunct to primary survey, there itself, if the patient is ABCD, followed by you have to go for ABG, ECG. If the suspecting reproductive age, we can go for beta HCG, CBG she has done, and also the FAST. So early you have to go for finding out the cardiac cause there itself, even respiratory also, because dyspnea patients, the most commonly we have to do things we can early find out, that is pulmonary edema, pneumothorax, and even cardiac problem there itself. In the adjuncts itself you can make out. So that also make a habit of doing that early before finishing the secondary survey. Nothing much. Well done, PRS team. Thank you.
Thank you. Thank you, Dr. Shiju. It is going to be 9:30. If there are no other questions, we can. Yes, please, Prathapan, sir. So, can you unmute, please? Prathapan, sir, please unmute.
You want to add something more, sir?
Prathapan sir muted ആണ്. ഇപ്പം
Yes,
unmuted.
yes. Good evening to everybody. കേൾക്കാൻ പറ്റുന്നുണ്ടോ?
ഉണ്ട്.
ആദ്യമായി എനിക്ക് ഈ അവസരം തന്ന നമ്മുടെ പ്രദീപ് കിടങ്ങൂറിനോട് എനിക്ക് വളരെയധികം നന്ദിയുണ്ട്. പിന്നെ PRSന് ഈ അവസരം നൽകിയതിൽ അതിനേക്കാളും കൂടുതൽ നന്ദിയുണ്ട്. നല്ല ഭംഗിയായി ഈ കേസ് പ്രസന്റ് ചെയ്ത അമിതയ്ക്കും കേസ് വർക്കപ്പ് ചെയ്ത ജനക്കിനും ഡോക്ടർ പ്രിനീഷിനും നന്ദി രേഖപ്പെടുത്തുന്നു. PRSന്റെ പേരിൽ ഒരിക്കൽ കൂടി നന്ദി രേഖപ്പെടുത്തിക്കൊണ്ട് നിങ്ങൾക്ക് ഗുഡ് നൈറ്റ് പറയുന്നു.
Thank you, sir.
Thank you, sir. Pradeep sir, shall we conclude?
Yeah, go ahead.
Okay. So a brief vote of thanks, official vote of thanks from my end. So once again, I really want to firstly congratulate Amitha for that excellent presentation. There wasn't much for us to discuss because at every stage, just like a very full-fledged academic discussion, she has stopped at the differential diagnosis after the symptoms, after the preliminary workup, why she thought about each of that, and very systematically gone through the diagnosis of SLE in such a case. And there was a lot of learning points which makes all of us think about these different things when we come across such atypical cases. So first of all, congratulations to Dr.Amitha, and thanks to our IMA President Vijayan sir and AMC Chair Dr.G.S.Vijayakrishnan sir, who kind of took the leadership initiative to start our journal clinical club and the AMS academic activity of the IMA group. Obviously, Pradeep sir for heading us, the PRS team, Dr. Prathapan sir, and our two discussants, Dr. Prinish and Dr. Janak, for working up the case as well as helping Amitha present it in an exhaustive manner and teaching us all those learning points. So great. We were able to conclude in an hour, particularly because the case was very precisely and presented, and we finished the case in 25 minutes and we had 15 minutes of very productive discussion. So we, and I thank all the audience. We had close to 55 audience. Some of them were postgraduates and some of them were doctors, I believe. I would like you to spread the word because we will be doing such a clinical club every month. And I think each of the academic team in the city will get an opportunity to present. So get back to your PGs and ask them to come up with an interesting case which might be useful for the rest of the group. And we look forward to more such discussions in the future. Thank you once again, all of you, for joining today's AMS Clinical Club. With that, we will conclude. Have a good night, everybody.
Good night.